And so this is pathophysiology, imbalances in fluid and electrolytes and other minerals. What I've done is I have culled all of the background slides and have just included the slides and the information that would be on the exam. So having said that, here we go for the fluid part. I do want you to know that about 2/3 of all the fluid that's in your body is inside cells. That's intracellular fluid. And the other third of the fluid that is in your body is outside the cell or extracellular fluid. And so that could include plasma, interstitial fluid. I don't need you to know or memorize the liters, but I do want you to know about 2/3 of the water in your body is inside the cell, a third is outside the cell. Okay, so life has decided that water, H2O, is going to be the universal solvent on the planet Earth. A solvent is what molecules can dissolve into. And we have a lot of electrolytes and non-electrolytes inside our body that interact with water. And part of it is going to be the organic molecules that we're made up of, carbohydrates, lipids, proteins, nucleic acids, and the other are the electrolytes. And they are salt, sodium chloride, and potassium chloride. Sodium chloride is mainly found outside of cells, and potassium chloride is mainly found inside cells. And that is going to be important because sodium and potassium chloride are going to be able to set up action potentials to conduct electricity in our brain, our heart, our smooth muscle, our cardiac muscle. Very important. And water is important in that it's very stable over a wide range of temperature as far as in a liquid state. And so many chemicals can so easily dissolve into it that it has been chosen by life to be the solvent of the body. Okay, so how can you get fluid moving from one compartment to another? In this first sentence, osmotic and hydrostatic or water pressure. Now, osmotic, that could be changes in salt, that could be changes in sugar. I'm not going to emphasize sugar right now, but when we get to talk about diabetes, I will talk a lot about sugar because sugar can draw water to it and salt can draw water to it. Uh, for this lecture, I'm mainly going to emphasize salt because we're going to talk about high sodium, high potassium, low potassium. But when we talk about diabetes, I will add sugar to that. Hydrostatic is water pressure, blood pressure, fluid volume, and obviously water goes from high to low pressure. Water can go from high to low concentration as well. So the big thing about this is actually shown in the next slide. You learned in Anatomy and Physiology 1 that one way to get equilibrium of the amount of salt inside and outside of red blood cells is to do osmosis. That has to do with the fact that salt is not readily permeable inside cells, and that is going to include the sodium and potassium chloride as well. So if you cannot move salt in and out of cells very easily and you have an imbalance, then the way that the body solves that problem is to move water. So osmosis is the movement of water from high to low. In this particular case, the solution that is changing is the plasma. So in hypertonic, here you have red blood cells that are in a very high salt plasma, and the red blood cells want equilibrium. They want the same amount of salt in and out. And if they can't move the salt, they're going to move the water. So in order to dilute out the high salt in the plasma, water's going to leave the red blood cell and shrink. Now, isotonic is the best of both worlds. Everyone's in equilibrium. The salt inside, the salt outside is perfectly equal. Iso meaning equal, and the red blood cell are very happy campers. Hypotonic is a situation where the plasma is too low in salt, hypotonic. And again, red blood cells want equilibrium. So the way that they do that is to move water from the plasma, where the salt is low, to the red blood cell, where the salt is high. And the cell swells. Bottom line, red blood cells don't like to shrink and they don't like to swell. They can tolerate it for a short period of time, but it wants equilibrium quickly, and that is going to be the purview of the kidneys, which we will talk about later, as in a week later. Okay, so um, the big thing about this particular slide is that obviously you want to have osmolarity, osmosis, salt concentration to be at homeostatic levels, meaning that it is equal inside and outside of cells. Now, what happens if all of a sudden you lose a lot of water, you hemorrhage, for example, and that would mean that you have more salt but not enough water in the cardiovascular system. So the thirst center is the hypothalamus. And if you are losing water because of hemorrhage, then you're going to stimulate the thirst center in the hypothalamus to start a series of reactions which you are going to perceive as you are thirsty, so that you will drink water, and that will help. Now, in the meantime, you also have certain hormones that will regulate this and help out. So, for example, besides you're taking in water, your posterior pituitary is going to release a hormone, ADH, anti-diuretic hormone, and that will help reclaim excess water that's in the urine and return it to the blood. Um, and if, for example, there's a decrease in osmolarity, a person drinks, I don't know, 2 liters of water all of a sudden in 5 minutes, then they're going to have a rise in blood pressure and a rise in blood volume. And what you want to do is get it back to homeostasis. So you are going to inhibit the thirst response in the hypothalamus, and you're going to inhibit the release of the hormone ADH. What that means is that most of the water now is in the urine, and you will pee out the excess by inhibiting ADH. So that's a good thing. Drink too much water, you pee the excess out, ADH is low, you lose water like in hemorrhage, then the thirst center gets stimulated and ADH levels go up, and you try to move as much water out of the urine back to the blood to compensate. Okay, so there are other regulators, other hormones that I want you to know. And besides antidiuretic hormone, there is a system called the RAS system, RAAS. Starts off in the kidney. We'll go through it in a sec. And there's also another regulator, and these are specialized cells in the atrium of the heart, of all places. And it's called ANP, atrial natriuretic peptide, which I'll talk about after I talk about RAS. So, RAS. This is a response to low blood volume, low blood pressure. The kidney itself is going to be able to sense that, and I don't need you to know that it's the juxta glomerular apparatus. That I don't need you to know, but I need you to know that the kidney releases the hormone renin. Renin is going to start a cascade that will result in a very vasoactive compound called angiotensin 2. It can systematically raise the blood pressure, and by having vasoconstriction go on, then the fact that the person's blood volume and blood pressure is low, that can compensate so that the person doesn't lose delivery of oxygen to places like the brain. Um, the other thing that angiotensin does is it can act on the adrenal glands that are on the kidney to release a hormone called aldosterone. So R is for renin, A is for angiotensin 2, the other A is for aldosterone, and the S is a system. So aldosterone is going to act on the convoluted tubules of the nephron in the kidney and have it reabsorb salt and water, sodium chloride and water. So, and if there's any excess, very, very high potassium, it can get rid of it at this point. And that way, between ADH and the RAS system, you have the ability to reclaim as much water and electrolytes as you possibly can to get back to homeostasis. And you're taking it from the urine and returning it to the blood. And that can solve a lot of problems. So that is if the blood volume, blood pressure is low. What happens if the blood volume is high? Then you can have the atria be stretched, and it is going to respond by producing a hormone called ANP, atrial natriuretic peptide. What it's going to do is going to block the kidney's ability to reclaim the sodium and water. If the sodium and water doesn't go from the urine back to the bloodstream, it's trapped in the urine, and you will have an increase in urine output, which is exactly what you want. If you have too high a blood volume, a person has taken in too much water suddenly, then you want that to go out the other end, and AMP can help that by blocking any reabsorption, and that way it's trapped in the urine. You urinate it out of your body, your blood volume goes back to normal, and everyone is happy. So that is 3 ways that the body always regulates it besides your taking in water. All right, so we have the regulation of water intake being driven by the hypothalamus and these 3 hormones. So now we're finally into disorders. So that's the way it normally happens. Let's get to the abnormal. There are 3 principal disorders: dehydration, hypotonic hydration, and edema. So let's take dehydration first. So dehydration could be that the person has lost a lot of water through sweat. Prolonged vomiting or diarrhea is another great way to get someone dehydrated. Hemorrhage is another way to get someone dehydrated. And let's just use those as examples. Your signs and symptoms: you're going to have a dry mouth, you're going to be very thirsty. There also should be low urine output. Remember that what your body's trying to do is it will play with those hormones and try to get you out of dehydration. What if they can't? Well, it can then, if you can't remedy the dehydration, it can lead to mental confusion. The low blood pressure and blood volume can lead to hypovolemic shock. Remember that every cell in your body, especially your brain, needs a constant delivery of oxygen. And that comes with red blood cells, and that comes with circulation, and that comes with blood pressure and blood volume. And if that is very dangerously low because of dehydration that you cannot correct, then the person has to present to the ER quickly in order probably to get an IV drip to get them hydrated as quickly as possible. Otherwise, they can go into hypovolemic shock and die. Next on the hip parade, hypotonic hydration. It seems like an odd term because you're talking about hydration, but you're talking about hypotonicity. What are you talking about? What you're talking about is if you drink too much water, plain water, very, very quickly. hypotonic hydration is also called water intoxication. And one example that I can offer is a person, and she lived in Newton, and she died after a competitive bike race because as she was sweating, it was a hot day, she got it in her mind that the only way that she could properly rehydrate is to drink distilled water. Problem with distilled water is just water. Usually, sports drinks or smart water contains electrolytes because you sweat your electrolytes as well as your water. You sweat sodium chloride. She was not replacing the sodium chloride, she was just replacing the water. And her red blood cells started to swell because of that, because the plasma was hypotonic, water was going into the cells. And the red blood cells eventually burst. They all burst at the same time. She dropped dead. And that is a really extreme example of hypotonic hydration. She had plenty of warning. Um, so you can have severe metabolic disturbance. She was nauseous. She might have been stopped to vomit. I don't know exactly what happened, but in spite of warning signs by the body, she pushed on. And then she pushed to a point where all of the red blood cells burst because of the hypotonicity, and no oxygen got to the brain, and she died. What could have saved her is to drink smart water or sports drinks during the cycling event, or to get her to the ER to IV hypertonic saline into her. But unfortunately and tragically, that did not happen. Okay, so edema is a third pathophysiological problem with hydration. So, edema is going to be the movement of the fluid from the blood into tissue. And edema can be very normal outcome of any sort of inflammatory response. If the inflammation is abnormal, pathological, then that's a different story. So, so increased fluid out of the blood and into the body can cause swelling, and the swelling is called edema. So swollen ankles, maybe because a person is elderly and is having some cardiac problems, they have swollen ankles, that's edema. Now, if the fluid that comes from the cardiovascular system and goes into the abdominal region, which is going to happen when we talk about kidneys, for example, um, and in response to certain problems, let's say with the liver. And you get an inflammation and you get fluid accumulation in the abdominal cavity near the liver. You call that ascites. And I do want you to know that because it's very specific. And it tends to happen in end stage kidney failure for whatever the reason. So ascites is fluid buildup in the abdomen. Edema is fluid buildup in other tissues other than the abdomen. And again, the treatment would be to try to get to the underlying cause. What is causing the inflammation? What is causing the liver problems? And that's really the only way that you can get to the heart of the matter. Okay, so we did water. Let's do electrolytes. And our electrolytes are going to be sodium and potassium chloride. And I've tacked on calcium because calcium is also important for electrical discharge down a neuron. It's also important in muscle contraction, cardiac, smooth, skeletal. So that's the other reason why I tacked on calcium as well as sodium and potassium. And here we go. High sodium. The thing about sodium is that you need it for action potentials, and it should mainly um, be at a homeostatic level where the neurons and the muscle are able to access sodium. But like anything else, it has to be at a homeostatic equilibrium. If it gets too high, we call it hypernatremia. Everything is Latin. So natremia is Latin for sodium, which is the reason why we say that sodium is Na. So that's an abbreviation for natremia, which in Latin means sodium. Okay, so what are the causes for abnormally high sodium in the blood? It could be water loss, where you just lose the H2O and you don't lose the sodium. Then that can happen in fever, for example, or the person is having a problem with sodium excretion that can't get the excess out. And those are people that are in renal failure. And when we cover renal, I'll bring this up again. Now, the symptoms, the ones that I want you to know for sodium, has to do with this last one. Seizures are due to water loss in neurons due to hypertonic cerebral spinal fluid. So I want you to go back to that image about the red blood cells. Cerebral spinal fluid is what bathes the neurons, just as plasma bathes red blood cells. If the cerebral spinal fluid has too high a sodium content due to some abnormality like renal dysfunction, then what happens is that you end up, excuse me, taking water out of the neurons as a way to get back to equilibrium. The neurons shrink. They don't like that. And what they will do is they will seize, they will cause seizures. And you're going to find out that whether the sodium is too high or too low, the brain is going to seize if it goes to extremes. And that's what I want you to know. So the treatment, however, is pretty easy. If you have too high sodium, drink some distilled water, believe it or not, and then you can get that sodium levels back down. Now, hyponatremia is too low sodium in the blood, and this can be due to excess loss of sodium. Um, Polydipsia, love that name. It means ingesting too much water in a short period of time. This is distilled water. So this is another thing that happened to the woman who tragically died by just replacing water in that sodium um, when she did the bicycle run. Now, in addition to polydipsia or losing too much sodium uh, due to, let's say, severe sweating, and guess what? You can also have hyponatremia and renal disease. Now, we will talk about severe vomiting and diarrhea a little bit later on when we get into acidosis and alkalosis. But I also want you to realize that if a person has vomited quite a lot, they are losing sodium and diarrhea as well. So that's other things that can happen with hyponatremia. The symptoms, the ones that I want you to know is the seizures. Again, these are going to be extremes, but the extremes are what I'm going to ask you on the exam. And to associate problems with seizures with too high, too low sodium is what I want you to realize because it's osmosis. It's an osmotic effect. So just like your red blood cells, if it was hypertonic plasma or hypertonic cerebral spinal fluid, the cells shrank and you had seizures. The opposite can occur. You can have hypotonic cerebral spinal fluid. So the water is too high, the salt is too high inside the neurons. Water enters, the neurons swell. Again, they're not happy campers when they swell. And so the swelling is going to cause the seizures. So either too high or too low, brain does not like that. Neurons do not like to shrink. They do not like to swell. And if they either shrink or swell, they go into seizures. Now, in this particular case, if you're very low sodium, IV some normal saline into them, they're going to be okay. The underlying condition could be something transient, like vomiting or diarrhea, or it could be something that's kind of constant, like renal failure. All right, potassium. So if sodium was all about the brain, potassium is all about the heart. And that's what you need to know. So whether potassium is too high or too low in the plasma, you are going to have heart problems. And of the type that either too high or too low potassium can kill. So here we go. This is this is a lot of jargon. What this is important is the fact that the heart needs to pull potassium from the serum in order to do a good action potential in order to contract. Um, your skeletal muscles, your smooth muscles, tend to recycle the sodium and potassium, and they're not as reliant on serum potassium as the heart is. And that's a big difference between the action potential of the heart and of the skeletal and smooth muscles. So that makes the heart very susceptible to stopping and killing the person if the potassium levels are either too high or too low. All right, so the next slide is going to be right, hyperkalemia too much, hypokalemia too little potassium. Kalemia is the Latin for potassium, which is the reason why we use K, because everything is Latin. So both high, too low can kill you and cause sudden death. All right, let's take hyperkalemia first. High potassium. Renal insufficiency, son of a gun. I am not going to cover the medications. You'll get that in Farm. And I'm not going to go into Addison's disease. I just want you to know about ineffective elimination due to renal disease. Renal insufficiency is renal disease. The symptoms, I want you to know this. It's just such a great synonym. Murder. M is for muscle weakness. U for urine oliguria, meaning less urine output. Respiratory distress is the R. D is decreased cardiac contractility. E is for ECG changes. And R is for reflex disorders. Okay, now, so too high potassium can decrease cardiac function, decrease pacemaker, then the heart stops working and the person dies. What can you do? You can get them to the ER as quickly as possible, and the treatment is so unusual, but so brilliant, and you know I'm going to ask you on an exam. The treatment is to give the person a wee bit of insulin, not a big dose of insulin, but a little jab of insulin. We always think about insulin as controlling sugar in the blood, and it does, but it also transports excess potassium out of the blood back into the cell, where potassium is normally very high, which is good. That way, you get the excess out of the blood, the heart is happy. You don't give somebody a lot of insulin, just enough to get that excess into the cell. Not so much that you couldn't drive their sugar level down and kill them, but enough to get them out of danger of their heart stopping. So that is hyperkalemia. Hypokalemia, low potassium. Now, this is going to be brought up again when we do acid base. But when you have kind of constant vomiting or constant diarrhea, I'm not going to get into medications on this exam. You lose sodium, you also lose potassium. And the potassium is going to be difficult for the heart to deal with. So it causes slowing down, muscle weakness, and constipation. Here's what's going to kill you. Dysrhythmias of the heart. Your heart goes into fibrillation, you can't get rhythm back, and the person dies. In addition, the person can also experience paralysis and respiratory depression, which can also kill them. But the big thing is the heart. Too high, you die of heart failure. Too low, you die of heart failure. So the treatment is to give the person some potassium. But just like the hypokalemia, you have to get to the underlying cause. Because look at the causes. This is going to be severe vomiting and diarrhea. You need to get a handle on those two things. Then, under the best of circumstances, if you can treat the diarrhea, if you can treat the vomiting, the potassium levels will go back to homeostasis and everyone's happy. So that is the potassium. Now, the calcium I have here is because calcium is also needed for a proper action potential, whether it's your nerves, whether it's your muscle. Because calcium in muscle is all involved with actin-myosin and getting a good contraction. Calcium is also important in neurons because you need it for neurotransmitter release into the synapse. So sodium and potassium are for the action potentials that are needed for muscle and for nerves. And calcium is needed for neurotransmitter release for the nerves and for actin and myosin interaction for the muscle. So you don't want to have too high or too low calcium for that reason. If hypercalcemia, it's a very rare, it can be caused by hyperthyroidism. We'll cover that in about 2 weeks. And can cause muscle weakness and extra clotting time in the blood. The treatment is a hormone made by the thyroid called calcitonin. Calcitonin can move that excess calcium out of the blood and into your bone. Hypocalcemia, too low calcium, can also be caused by renal failure. And it can cause CATs. I do want you to know CATs. The C is for convulsions, the A is for arrhythmias, the T is for tetany, and the S is for spasms. And the treatment is to give the person calcium. And we are now at the end, and we have covered fluid and electrolyte and calcium imbalances, and that is all. There is no more.